Hi, everybody. Mary Jane Burke here. Happy to have you join us this afternoon. Just as a reminder, I'm sure this feels like a broken record, but as a reminder, this session and the PowerPoint will be available to you within 24 hours or earlier on the Rethinking Schools site. And the session is being translated and live translation is available in Spanish. So Marta, do you mind, is it Marta that's going to give a message here?
Hi, Mary Jane, it's Michelle.
Okay,
Hi there. Hola, bienvenidos. Este webinar se transmite simultáneamente en español. Haga clic en el botón de interpretación del idioma que aparece en su pantalla. Si desea escuchar esto en español, muchas gracias a Marta Bitton, que es nuestra intérprete esta tarde. Thank you so much.
Great, thank you so much. And so I just want to say great thanks to Dr. Matt Willis, Dr. Santora. As many of you know, for those of us that are counting, in just a few days, it will be 2 years since we first began this journey together. And in the final analysis, without the strong support from public health, the leadership, the willingness to be available to us on a moment's notice. I think this is like the 300th session that we've had in these years, but I think it made a difference for our community. So Dr. Santora, I'll pass it to you with great thanks. Thank you.
Thank you, Mary Jane. We can jump right ahead. Our favorite slide. This is, I knew we would get here when January hit us and we returned to school. And I had anticipated it would be a pretty quick wave because of the contagiousness of it, but that in no way diminishes the challenges that we've had in what's going on now over 2 months, navigating through the Omicron surge and ensuring students could return to school for in-person instruction. But you can see the tide is ebbing now, and we are, I have even more good news as we jump ahead in slides, but we're seeing around 25 cases per day right now, which is very different than the days that we had over 1,000 confirmed cases during the peak of the Omicron wave. So things have fared much better, which is good news. You can jump ahead. And this is just the cautionary slide that we have confirmed the Omicron BA.2 variant is in our community. We had assumed it was not circulating in our community, but we do have confirmation now. The concern around this particular variant is not that it's going to cause another wave of Omicron, but it just might lengthen the tail of this wave and potentially thicken the tail as this more particularly virulent or causing more severe disease version of Omicron is circulating in our community. But at this time, we just think it could extend and thicken that tail of the wave. Jump to the next slide. And this is another good news slide. We are starting to get a lot more data around children, and I think this supports the decisions that we are now seeing to relax the mitigation strategies that are in the school setting while still staying vigilant. You'll see that for our youngest age groups, when you compare COVID to RSV or respiratory syncytial virus and flu, that there's a much lower risk of disease to our youngest population, our 0 to 4 population, than flu or RSV. Similarly, you'll see the same for COVID-19 as it relates to our 5 to 11-year-olds or elementary school age children. But notably for this disease, and not unsurprisingly considering what we've learned over the past 2 years, is that there's the highest risk in our adolescent population for our hospitalization. And I know there's a lot of conversations around adverse effects from vaccines, which of course is always concerning. But what people forget is that you're more likely to have adverse effects from COVID infection itself. And so this is just a cautionary slide as we navigate through the next phases of just the importance around boosters for the adolescent population and why we'll continue to address disparities in vaccinations across our community. You can jump ahead. And this is just another important slide to share, in that I know many people know individuals who had been vaccinated and had been boosted, but still got sick with COVID. But this slide, again, just really crystallizes the differences between being unvaccinated, fully vaccinated, and boosted. And you'll see that the highest rates, this is when we try and compare apples to apples, the highest case rates throughout the surge and the peak of the Omicron wave were among our unvaccinated populations. We also saw a 40% protection among those who were boosted compared to those who were fully vaccinated, not boosted yet. So everything does return to the mean, and that's why you're seeing decreasing case rates among all three groups. But again, boosters continue to play a critical role in protecting our population. The reason why you experience knowing people who were boosted and had COVID-19 is if you look at that boosted group, that green line, as significantly lower it is compared to the other groups, it's still higher than what we experienced at that peak wave, looking back to July into September of 2021 with the Delta wave. So that's why you experienced either yourself or someone you know being boosted and getting infected with COVID-19. It was because of the high contagiousness of this particular variant, but in no way does it detract from the protections that vaccination and boosters offer to our community. Jump ahead. I think this is a really important slide because we're naming viruses in an alphabetical order. And what Omicron, it's important to know that Omicron, and to prepare for other variants, Omicron might have been in alphabetical order, but it is in no way a direct descendant of Delta. And we are now learning a lot more about Omicron. It's going to take more research and more studies and analysis to determine and start tracking back where Omicron came from. But they think its earliest ancestor came from somewhere in 2020. And so that's why it had so many mutations and behaved so differently. And I think that's what we really need to be prepared for. We need to prepare for both the descendant of Delta, even though Delta isn't circulating as widely in our community now, but to be prepared for a descendant of Delta, but also to be prepared for a variant that might, again, in alphabetical order, might feel like it's a descendant, but it's completely more unrelated to our most recent experience of a variant than what we have had seen in the past. So this is just something I think it's really important to be aware of what we're preparing for, both variants that are direct descendants of Delta, even possibly variants that are direct descendants like the BA2 variant of Omicron, but also we need to be prepared for the emergence of other variants throughout the globe, especially as the majority of the globe remains under vaccinated and absolutely not boosted at all. You can jump ahead. Good transition up to our vaccine update. So again, as I've just reinforced, vaccines continue to be really important for our community and for protecting especially individuals, especially those at highest risk. There is waning immunity, there's waning natural immunity and waning vaccine-induced immunity. And what we saw with Omicron is that partial escape. And the slide already spoke to that. I think it's also important to point out that this is considered a zoonotic disease. If you remember back to 2009, H1N1 was originally called swine flu. We're concerned always about bird flu. That's because when viruses jump back and forth between human and animal hosts, there's higher rates of mutation. And that's also what we need to be prepared for as we have high levels of disease circulating in the community and already evidence of hopping between animal species, which increases the rates of mutation. Just also, you may have seen reports in the news around the effectiveness of pediatric vaccines, and I have a couple of slides on that to share with you. We think that dosage really is playing a more important role, especially in the 5 to 11-year-old population than was anticipated in the early development of the vaccines themselves. We already have seen for the adult population that Moderna, which has a significantly higher dose than the Pfizer vaccine, has offered more protection to individuals, and it's partly attributed to the higher dose and is also attributed to potentially the longer interval between the first dose and the second dose. And then I think that will be the primate study, and we'll share the slides that I mentioned, just shows that in primates and animals that received higher doses of the vaccine had higher levels of protection than those that received lower doses. So this is, I think, something that will be emerging, that you'll be seeing in the news in the months to come, especially as they potentially prepare a vaccine to launch into the 0 to 4 population, as well as preparing for what might be the right dose for a booster for a 5 to 11-year-old. So a lot still to be seen. The speed of science is not faster than the speed of social media sometimes. So I know our community gets ahead with news around what's emerging. And I just can affirm that we will remain committed to the evidence base prior to making any recommendations around vaccines for the youngest pediatric population of 0 to 4, as well as boosters for the 5 to 11-year-olds. But we are consistently seeing that boosters are incredibly important. We see that individuals that have received their boosters have significantly higher levels of antibodies, as well as the B cells themselves, which produce the antibodies. And as I already mentioned, we'll be looking to booster guidance. And what's included here is just the links to the New York State study that showed lower effectiveness of the vaccine in that 5 to 11-year-old population, as well as to larger studies from multiple states that are 10 states that are participating in a surveillance system called the Vision Network that showed the effectiveness of the vaccine in the pediatric population. So you can jump ahead. I have a couple slides just to show that effectiveness, I think, is really important. So what you're looking at here first is the vaccine effectiveness against emergency department and urgent care visits. So these are two, it's a distinction when we're looking at outcomes, we're looking both at hospitalizations and then also use of more intensified resources like urgent care and emergency department. You know, when you take your child to the emergency department, it's different. The parent instinct is different than something like the common cold. So you're concerned about a higher severity of disease and are seeking acute evaluation of your child. So at this slide, I know it looks a little bit busy, but you're looking at a comparison of Delta, which are the first 3 columns, and then Omicron, which are the last 3 columns. In the first 3 columns, you'll see there is no data on 5 to 11-year-olds because we did not have a vaccine for 5 to 11-year-olds. But what we did see with both 12 to 15-year-olds and the 16 to 17-year-olds was significant effectiveness against those emergency department and urgent care visits. Notably, we saw a waning of that effectiveness. You can see a significant decrease in that orange line, and that's where individuals where it's been 150 days beyond their second dose. So around 5 months after their second dose, you start to see that waning immunity of the vaccine-induced immunity. Now you jump to the last 3 columns, just looking at Omicron, and we see reductions in ED visits and urgent care visits across all ages, and it reduces with age group, but it's still significant protection. What's important to see for us is just the protection that even with Omicron, that when 16 to 17-year-olds got their booster dose, it returned to higher levels of effectiveness against protecting from these more acute care visits. So again, just reinforcing the importance of boosters in our community. And we still have a lot to learn on whether this will be kind of a 3 and done vaccine series, or is this something that we're looking towards a seasonal COVID-19 vaccine, or is it seasonal only for those at highest risk for adverse outcomes, which would be really the population over 65 and those who are immunocompromised or have other chronic conditions that place them at higher risk for severe illness. Can you jump ahead? So this is kind of a look at the same slide, but it's looking at hospitalizations. And this is looking at Omicron only. And so we're looking at the protection that vaccines offered for hospitalizations. You see that it was effective in preventing hospitalizations among 5 to 11-year-olds. Again, I think we hear in the news that this is a mild disease in the pediatric population, which it is. But when we share case rates, these are national case rates, and you're seeing numbers per 100,000. So if I share a case rate that says 32 per 100,000, you have to multiply that to have an estimate of the total number of hospitalizations that we have seen for the pediatric population nationally. And they have been significant numbers of hospitalizations. And so there is protections offered against hospitalizations offered by the vaccine. And with these 2 slides, again, you see that waning immunity that is experienced even in the 12 to 15 and the 16 to 17-year-old age group, which again provides further evidence of the benefits of the booster shot for the 12 and up populations. And as I said, we'll be looking to see the research surrounding the recommendations for boosters for a younger population. Jump ahead. So our goal right now in the community is ensuring vaccine equity. We're seeing growing disparities of primary vaccine series in the pediatric population among communities of color in our community. And so we set goals or priorities in our action plan or emergency response on a weekly basis. And then our team works to achieve those goals. It's important for us to set measurable goals. So we set a goal in February to increase the percentage of 5 to 11-year-olds with first dose by 50% in our Latinx and Black and African American communities by the end of this month. We've made progress, but we still have a significant more progress to go. So at this time, we have 52% of our 5 to 11-year-olds in the Latinx community have received their first dose. And so we have 329 more doses to go to achieve that goal. And we have a smaller Black and African American population, and only 24% of 5 to 11-year-olds in that group have received their first dose. And just to put into context, it's over 75% of children in Marin County between 5 to 11 have received their first dose. That being said, even among communities of color in Marin County, it far exceeds the rate of the state. We're very, very far ahead, but we still are seeking to achieve equity in distribution and making sure that there are no disparities based on race and ethnicity. Jump ahead to the next slide. So the new framework, a couple of weeks ago, you saw the introduction of a new framework that shifts from a prioritization placed on community transmission, which is the level of virus that's actually circulating in the community, to COVID-19 community levels, which really focuses on the healthcare infrastructure and ensuring that we have sufficient capacity to meet the healthcare needs of those who are experiencing severe illness due to COVID-19. You can jump ahead. So I have this year, the first public announcement I've had today of the very good news is we are the first Bay Area county in the state to achieve moderate levels, or yellow, which is very exciting. It's taken us a while to get here, and I think we have achieved this again because of our high vaccination rates and high booster rates in our community, as well as strong adherence to public health recommendations. And again, an overall healthy community has set us up for success. So this is very exciting, but to remember, this is the community transmission levels. This is the amount of virus that's circulating in the community. We really think this has now become an underestimate, which is why one of the reasons why the CDC is phasing this out, because more people are finding out they're testing positive for COVID-19 through rapid antigen testing at home. And so a year ago, there were no rapid antigen tests at home that you could test yourself and then follow guidance around isolation or quarantine or testing contacts. We didn't have that capability. We now have that capability, but what that does now is that it underreports the level of disease in our community. But this is very good news. You can jump ahead. And also good news, we just took a look at the transmission rates by age group as well in our community. And this was before I think I did this slide a couple of days ago. So this is before our community level attained the moderate level. We were still in substantial and high levels of community transmission. But what you could see is that our school age population had already decreased to moderate levels of transmission, which again supports the relaxation of COVID-19 mitigation strategies in the school setting. And you'll continue to see that we still have a little higher rate or substantial rate of community transmission in the 0 to 4 population. Not surprising, again, it remains the unvaccinated, the predominant unvaccinated population in our community. Jump ahead. So this is our new framework. So that was the past and this is the present. You can see that we're in that top group where we have fewer than 200 cases per 100,000 people over the past 7 days. You'll see that the state is turning green, which is predominantly on the coastal part of our state due to high vaccination rates are contributing to the rapid reductions. And then some of the reductions that you'll see in the other parts of the green state is there are more rural communities where there's just not high population. So it's disadvantageous for COVID-19 to be circulating in more rural communities. But this is where we are. And when you look at the indicators, you'll see it's really hospital oriented, where we're looking at the admissions per 100,000 into our hospitals. And then we're looking at how many inpatient beds are occupied by COVID-19 patients. So it's really looking at the burden of COVID-19 on our community. And to remember, what's different than from a COVID-19 patient from another patient is that they're placed in isolation. And so not every room or bed in a hospital is an isolation room. And so that is adds an additional burden to our hospitals when they have to have a significant number of people in isolation. Jump to the next slide. So the recommendations, and this is where you're going to start seeing us aligning with the CDC. The recommendations when we're at a low level of transmission is staying up to date with your vaccines and boosters. So when you become booster eligible, get boosted. And importantly, having a plan for rapid testing. This is critically important because we all experienced in January what it was like not to have access to testing. And I know a lot of people were challenged by that. So now is the time to make sure that you know where to get tested and have and get some rapid tests yourself. And so you can jump to the next slide. And I'll do these two slides, Mary Jane, and maybe I don't know if we added the slide to talk about the school distribution. So this is just the link. And again, it's more important not to link on it now, but just you'll have it in your files to link onto our testing resources site. And you still can get free tests from the federal government through covidtest.gov. If your first order only got 2 boxes with your first order, you have 2 more boxes that are ready to be shipped to your house. And so we recommend everyone get their, it's not free, you pay taxes for it, so that everyone get their tax paid kits sent by the government to your house. And then there's also self-test kits online, or you can go to your local retailers, and all of these have links here. And then you can jump ahead. And importantly, since January 15th, you can submit, if you've paid out of pocket for your COVID test, if you have a receipt, you can submit a claim to your health insurance company. And that includes Medi-Cal, Kaiser, Blue Shield, and any health insurance company. Any COVID test purchase after January 15th is reimbursable through your health insurance company. The exception is Medicare, and they're expecting that to change by the spring. And I don't know if April's the spring or May is the spring in government language, but by the spring. Do we have a slide on the school testing, or did you want to speak to that, Mary Jane?
I'm not sure if we have a slide, but just for everybody to know, we just received another 80,000 tests, and we're in the process right now of getting them moved out into our schools, back to what our hope is, that, every school has a supply in the event that they're need to do any testing in real time, that at home there's tests available for both our staff and our students, so that we feel like right now we have a very good supply. So we're going to be moving it out. And so the information is coming through our school districts. Mike Grant, do you have anything you'd want to add to that?
Yeah, we've had a number of districts and schools pick up their tests today. And if any schools and districts who have not, you're welcome to come by the office. And if you have any questions, you can contact us at rethinkingschools.org.
Okay, great.
Yeah.
Great. But one of the things, just as a reminder, that, at this point, these tests are identified. We want them to be used for students or staff with symptoms, because down the road, we might not be, Lisa, I think you mentioned in a different meeting that we're anticipating the day is going to come where there's no more testing available, test kits available. So we may be entering sort of our last phase right now. So still, please treat them as precious, as we may need them in the future.
You may have seen on the news that there has been an extension of FEMA funding. That is not expected to provide us with ongoing access to public health emergency supplies of test kits. And that's what these test kits that Mary Jane just described are part of those public health emergency supplies that have been secured and procured by the state and then distributed to school districts throughout the state. We're expecting that by March 31st, it will end. There'll probably be a distribution of leftovers across schools. And so many schools may be sitting on tests during the summer and not using them at high levels. We've consistently seen extensions of the expiration dates of the antigen test kits. So that's not something we're worried about. Our expired antigen tests found a lot of Omicron during this winter season. So they still are very effective. So don't be worried about having tests that are passing their expiration date. What we've experienced is better to have a test that's after its expiration date than not to have a test at all. And that's what we're reorienting in our community, is everyone needs to prepare to access testing. And that might be, if you're a business or an employer, securing your own test kits for your employees. And again, we are seeing the end of these emergency test kits. So we have to start integrating it into our business. So budgeting for our businesses and budgeting for and planning for testing is something we have to plan to and not to expect the manna of tests from the state. Jump to the next slide. School masking, the hot topics. You can jump ahead. So we have seen tremendous benefits of masking in our schools. I know with the end of the requirement or mandate around masking, a lot of people have said it's because masks are not effective. That's not the case at all. We've locally seen the effectiveness of masking, not only in reducing the risk of COVID-19 transmission, but also in reducing other absences from other respiratory illnesses. COVID-19 is transmitted in two ways. It's both a droplet disease and an airborne disease. And the cloth masks are not as effective at preventing particle matters from being part of the room that you might be exposed to, but it certainly is effective at protecting the expelling of droplets. It protects you from rubbing your mouth and rubbing your face and all the different ways that you that droplets are shared in our community. And so we do see them as effective, and it decreases your risk of exposure. And with the end of the mandate, there's also benefits of ending the requirement, because we know that masks have interfered with the social and emotional development of children, especially our youngest age children. They've interfered with learning, especially children with special needs and access and functional needs. So again, we're trying to strike that balance, and I think we're very poised in Marin County to be leading the way in again, relaxing masking recommendations as we move forward. Jump ahead. So this is a busy slide, and it's probably something that you'll have to just take a look at afterwards, but I'm going to try and talk through it pretty quickly. This is studies done outside by Duke University in partnership with multiple school districts, primarily in North Carolina, but across the state. And really the studies are consistent with what we've seen nationally, is that masking does work. It works at reducing what we call secondary transmission. So it might not prevent the sick child from coming into the school, but when we had mask to mask exposures, we saw there were significant reductions in school-based transmission. And what you're looking at here is on the red line is there's no masking in schools. Yellow line is data from partially masked schools, and the green line is fully masked schools. And when you're looking at the bottom, you're looking at across your x-axis, you're looking at the number of primary cases of how many infected students came into a classroom. So your first cases into the classroom. And then when you're looking at that y-axis, you're looking at how many secondary cases, people that were exposed in the classroom and then had school-based transmission. And so if you look at that red axis, it took 145 primary cases, or those initial cases of COVID-19, to then have 30 secondary cases. And that's in your unmasked schools. In your fully masked schools, it took more than 1,000 students to have primary cases than to have 30 secondary cases of COVID-19. So again, just reinforcing the benefits of masking that we see. But jump ahead to the next slide. They offer, Duke's also developed a risk calculator. And I plugged in our district size and our current community case rate. And what you'll see is we really are in a very good position again, where due to low case rates, we are expecting, so this is our predictions for the future. So we'll see how we fare over the first 7 days. But with the current case rates, they would predict that we would have 20 primary cases of COVID-19 in that first week that we return to school on March 14th, where we don't have universal masking requirements. And so then they would predict that we potentially have 12 secondary cases because of the relaxation around mask. I'm not expecting the 12, because I think we're going to continue to see partial masking in our school. I'm estimating that probably 70% of students will continue to wear masks based on public health recommendations. But this is an estimate that's been based just again on developing models from analysis of past studies, and again working with school districts across the state. This model has been validated by multiple universities and children's hospitals who participated in these studies. So it's a great website to take a look at. But again, this data to me reaffirms the steps that we're taking to shift from a mandate to recommendations. And then I'll talk to you a bit more about relaxation, further relaxations in a bit. Jump ahead. So this is all you know already, is that the state's removing the requirements beginning March 12th. We are going to enter into the first week or so without the requirements for masking in school, with a strong recommendation that all individuals in school and childcare continue to wear a mask. That being said, based on the local data that I shared, showing you that we shifted from substantial to moderate, we're going to plan for our local update as early as March 23rd to relax guidance and to shift our language from strongly recommend to most likely the word will be consider wearing a mask based on individual conditions, for example, like risk immunocompromised or unvaccinated. That really is going to be based upon what we see in that first week or so of students returning to school with the relaxed masking guidance. If we see significant levels of school transmission, or do we see what's predicted by the ABC collaborative, which would not be seen, which would be expected levels of transmission. If we see higher than significantly higher levels of transmission, we may continue to have the strongly recommended language. But if we see that we are that we have stable and expected school-based transmission with few outbreaks, then we'll relax our recommendation. But again, I think the most important thing, we've been saying this consistently, and we know it's not consistently practiced. The most important step is urging everyone, including staff, parents and guardians, to keep sick students home and test for COVID. I can't tell you how many times, not just in schools, but just across all of our investigations, we've investigated now thousands and thousands of COVID cases, that it's the most common report is someone went to school or went to work, they had a sore throat, they ignored the sore throat, and then they tested for COVID. And so I think that's, as we're now relaxing the recommendations and know that it's not going to be required to wear a mask in schools, it increases our responsibility as staff, parents, and students too, is to report those symptoms and stay at home if sick until you test and your symptoms are resolving. Anything you want to add here, Mary Jane?
No, I think the number one, nothing's new about we're supposed to stay home if we're sick, right? Kids or parent, students or parent or staff, but it's really so very, very important. And so I just want to stress it. So very often, and then just a reminder that you can't, Lisa, describe what the issue is about not, you can't just give Tylenol and then send them to school.
Yeah, that's not an uncommon practice by working parents pre-COVID, is where child is just bordering on symptoms, and then you give Tylenol or Motrin and then ship them off to school. That's not the practice that we need to have right now, especially when we're just relaxing our masking recommendations. We want to be able to relax more, but we really are depending on parents. And I talked to multiple principals of schools. Your children and students will tell what happened before they come in, but then when they share their stories of when they got sick, it does become known when kids are coming to school sick. So again, especially in these first couple of weeks, as we relax our guidance, we really are just urging people to just partner with us. And I know it's hard. My son was home for the past 5 days. He did not have COVID. He had a sore throat. Something's been going around town, and it's hard to be a working parent with a child or two home from school. But this is what's going to allow us to relax our guidance more quickly, is following this. Probably this number one recommendation is keeping kids home when they're sick. Jump ahead. So the state has also updated its guidance. We have links at the end of the presentation. They just updated their guidance today. We're going to align with this. Is still strongly recommending mask indoors, especially with higher risk sports and other activities. And when actively practicing or conditioning, masks are still strongly recommended, especially for indoor sports. So I just cut and paste this straight from the state's updated guidance today. We have a guidance document that's out regarding extracurricular activities, and we'll be updating that guidance for release on March 11th. And you can jump ahead. The state finally at the end of Omicron, the state has more specific guidance around music, where again, they're recommending if you can't wear a mask, to use bell coverings when possible, and to try and maximize physical distancing between participant. The state is recommending, and this is what we'll be looking at our own guidance. The state is recommending that musicians and athletes engage in screening testing weekly if they're screening testing and weekly if masks are not worn. The exception for that and for almost everyone is if you've tested positive for COVID in the past 90 days, we don't see an additional benefit of participating in a screening program. If you've tested positive for COVID-19 in the past 90 days, you should just test yourself only if you develop symptoms consistent with COVID-19. We haven't seen significant amount of reinfection, but we are investigating a reinfection of that BA.2 variant. And so we have not confirmed it yet, but it is possible that you could have had the BA.1 Omicron and then also be infected with the BA.2 Omicron. It's possible, but it hasn't been confirmed. It wouldn't be as common. I'm not expecting that to be as common as what we saw is when people had a past history of Delta, but then they got infected with Omicron. That was not uncommon to see, especially among the unvaccinated populations. That's typically where we saw that pattern. Can you jump ahead? So risk assessment, I feel like I'm hanging in, stay home when sick and get tested. This has been a really important piece and we're gonna be updating our exposure notices. If a student tests positive in the classroom, our strongest urging and recommendation is that anyone that was exposed to a positive student or staff in the classroom, regardless of their vaccine status, wears a mask in schools for the next 5 days. The state's actually recommending 10 days. We're saying 5 days and test, wear a mask for 5 days until you test negative on day 5. And the reason for that is we're really trying to prevent those secondary transmissions and tertiary transmissions. So we're going from a space where there was only mask to mask interactions. We could be in a classroom 2 weeks from now where there's no one in a classroom wearing a mask, honestly. And then if we don't mask up after we find that first case, then what we've seen consistently is basically it just runs through the classroom and there's serial exposures. And then we, in 3 more positive tests, we have an outbreak. So our strongest recommendation, and we're going to be updating those notices, if a student is in a classroom where they have been exposed to COVID positive themselves, they should mask up themselves for the next 5 days and until they test negative for COVID-19. And just reinforcing the importance and recognizing that there are individuals that have different risks. And at this time, if you or you have a family member who is at high risk for severe illness, to really consider wearing a mask with greater protection, especially with that particle matter protection, the KN95. N95 is the strongest mask, KN95 is the second strongest mask, and the cloth mask offers very limited protection against particle transmission or airborne transmission. Jump ahead. So group tracing, one of the times earlier in January, we said no more notices. That's changed now that we're shifting. We're not going to do individual level contact tracing anymore. What will happen is what has happened with all the other reportable diseases. If someone tests positive for COVID in the classroom at the elementary school level, a classroom or group notification will go out. We'll be working with the secondary schools just to help them identify the scope of the notification if someone tests positives at that secondary school level. We know they're shifting multiple classes throughout the day. Again, just reinforcing one, that you should wear a mask for at least 5 days and get tested on day 5. But then 2, I probably should have highlighted the second bullet, since I've already talked a lot about masks, is really getting tested on day 5. So anyone who's had a known exposure, 5 days after that exposure, you should get tested if you're vaccinated or not, except for those who have a history of COVID-19 infection in the past 90 days. Jump ahead. So we are preparing for outbreaks. Our field team is getting ready and we'll be ready to support schools if there are outbreaks. Just to be prepared that there might be a return of response-based testing. Unlike before, we're no longer going to have modified quarantine. That's going away. So anyone that's exposed is able to participate in all activities, sports, after school activities. They just need to monitor symptoms and test on day 5, or test sooner if they develop symptoms. If they test positive, then they need to isolate immediately and notify the school. And again, reinforcing the importance of wearing face coverings after an exposure. Jump ahead. So these will be the links to the updated guidance. The top bullet was just posted today. It's effective March 12th. And like I said, we'll be updating the exposure notification forms to align with the new guidance. And then we're still waiting for an update from the CDC. The CDC hasn't updated its guidance since January, so we're still waiting that. If you click on that link, you'll find old guidance. We know that, but the link will be the correct link when they do update their guidance. And next slide, I think is our next steps slide. Okay, our next step slide. So we will be reviewing and updating the guidance. We're still going to wait for that CDC guidance. We're anticipating this to be the last update to our 32-point plan. And we'll be, as I mentioned earlier, we'll be updating that school guidance as it relates to performing arts, sports, and extracurricular activities. And then we'll be revising our school guidance once we have these final updates from CDC and CDPH and shifting away from that 32-point plan. And I think that's the last slide.
Okay. All right, great, Lisa. So let's go ahead and move into the questions. And I'm going to start with questions that were provided in advance of this, this session. What steps are being taken to ensure that teachers or other students will not make fun or scold students who choose to wear a mask or not wear a mask?
I think that's the first step. And if you look at to the CDPH guidance, the first bullet is really supporting everyone that chooses to wear a mask. And I think this is again where we have to go back to our kindness and compassion. And there's a lot we don't know about other families and the risks that they may have in their household. And so, and their own comfort levels, we're all navigating this pandemic journey at different speeds. And so you'll be seeing in our language, reinforcing the importance of accepting people's choice. And then secondly, meetings like this, where we'll be just again advocating for compassion and kindness as people are making decisions, and just recognizing that a lot of times we just don't know who's in someone's household and the risk that they may be carrying. I received a significant amount of emails from families that are really concerned about ending the mask requirement because of the protections it's offered their family who's living with children and adolescents and other household members who have really severe immunocompromised conditions, conditions that you're just thankful as a mom that you haven't had to navigate 2 years of an infectious disease pandemic with a child with lymphopenia and other diseases. And so just to be compassionate to those who are frightened and worried about this, these relaxed guidance, because it does increase the risk of an exposure for their children and family members. So I think the first step will just be us right now messaging and consistently messaging the importance. And again, at the school level, addressing when there is behavior that doesn't reflect our values, addressing that behavior quickly, so we don't let it to become malignant in our school community. It's time to relax. I know everyone's fatigued. There's anger and worry and fatigue and so much other stress that's amplified with, I think, some of the global realities that we're living in. And now is the time to we're getting there. And so let's just be compassionate with each other.
Okay, Lisa, given that we're in low transmission, why are you still strongly recommending masking? Can you just one more time hit that?
So have a low COVID-19 community level. Today, we just shifted from substantial community transmission to moderate community transmission. It's our first day, and there's still significant COVID-19 activity. Let's not talk about the hospitalizations, but the activity. So we are strongly recommending. That's going to, one, create the space for those families that are in this transition. It gives us an opportunity to align with the state and the strong recommendation. Schools are a different environment. In an elementary classroom, kids are in the same classroom all day long for probably 5 hours. So it's a different environment than our normal kind of public encounters and going in and out of Pete's or going in and out of grocery store. This is a population that is a congregate-like setting. And so that's why we're entering with the strongly recommended because of the current transmission levels. We're going to observe what happens over the next week and a half and make sure that once we have a change, there is going to be a change. Like I said, I'm expecting 30 to 40% of students to no longer wear a mask, and to see what does that look like. If we see stable transmission levels in the school, it's not skyrocketing or jumping up significantly more than expected, that's when we'll relax our language around the recommendation. We'll also are already relaxing our recommendation around outdoor masking and explicitly stating when the updated 32-point plan comes out, if that's what you get, explicitly stating that outdoor masking is not required because we do not see significant risk of transmission in most outdoor settings. So we'll be reinforcing the role of not using your mask out, having options around using your mask outdoors. My kids wear the mask outdoors because they like covering their face and they say they're cold, but I am the mom saying, take your mask off because I can't hear or understand you. That's why. So we are in a new low level. We still have new low COVID-19 community level. We just shifted from substantial to moderate community transmission levels, which we know are an underestimate of our actual transmission levels because more people are getting tested by rapid antigen tests that aren't being reported to public health. So this gives us a glide path to more relaxed measures.
Okay, Lisa, I'm going to go to the questions let me ask you this. There's a question that came in asking why there hasn't been outreach to West Marin. And I know there has been significant outreach. Can you talk a little bit about that?
So first we partner with the schools. I mean, they're part of all of our meetings and really thankful for our partnership with our schools. They were also great partners in vaccination and testing throughout the pandemic. Second, we have something called a community response team where the county is partnering with West Marin Community Services and develops outreach and education plans for the West Marin community in partnership with West Marin Community Services as a lead organization, but they're working with other organizations in West Marin as part of that community response team. So there are ongoing efforts. You can email me if there's any specific concerns in West Marin that we need to be called to public health's attention, and we can bring that back to our West Marin community partners.
So Lisa, this could be what some people are thinking. If there's a new variant that we're seeing in New York, other places, why are you even considering removing masks at this time?
Because of, again, we're shifting. We have number one, we have tools we didn't have a year and a half ago. We have vaccinations, we have treatments. We also have data. We are seeing low like I shared earlier, low hospitalization rates in the school age population. We still have tools people can use, and so they have choice around wearing a mask. Our new recommendations will not stop anyone from wearing any level of mask, from cloth to an N95 mask. And then lastly, we are seeing that shift in our community. The rates have gone down. We are benefiting in Marin County. We've earned this privilege in some ways. We have worked so hard to vaccinate our community and to boost our community. We're the first county in the Bay Area to return to moderate levels of community transmission or COVID transmission. And so now's the right time. And again, we fully support schools and districts that are going to opt to continue requiring a mask. They may have lower vaccination rates and other considerations. So we fully support that, and fully support families and students that continue to wear a mask, and also support the choice. And for me, it's really important that when we say strongly recommend, that it means something. And that's why I'm talking now ahead of the state. My first question, I was hoping, honestly, when we met with the state this morning, that they would have a very clear framework for an off-ramp for recommendations. So we could just align with that. The state hasn't developed that. So I have a meeting with ABAHO, which is the Association of Bay Area Health Officers, on Monday. I've already shared with them our recommended language and thresholds around changing our recommendation from strong recommendation to consider masking, because I do believe there'll be a time, not now, I think we are going to have, again, there's a lot of COVID still circulating, still need to be careful, especially at parties and small gatherings or large gatherings. But there will be a time where we're expecting a surge as early as the fall. And when Marin County Public Health says we strongly recommend masking, we want it to mean something as well. So that's why relaxing is just as important to me as aligning with the state, because I want to make sure that our recommendations stay valued and trusted.
Mm-hmm. Lisa, the data that you provided related to RSV, flu, COVID-19, was that from Marin County or national?
National, that was national data.
Mm-hmm. What percentage of children who test positive for COVID are hospitalized for COVID-related systems?
It's very low. It'd probably be less than 1%, easily less than 1% in our county. Most children we see have mild to moderate illness with COVID-19.
If we're checking preschool students in outside where a teacher's greeting parents individually, would you recommend that parents and teachers wear a mask at this time, even if it's outside?
I would say it's not required and that risk of outdoor transmission remains low. And I do think for our youngest age group, if you just think about 2 years in an adult lifetime is a long time, 2 years in a 0 to 4-year-old is a huge amount of time during such a critical development period. And to see facial expressions and to build those social cues, the benefits of being outdoors without a mask for that age group are high. But again, we respect our childcare facilities have been at the front lines of this pandemic since the beginning. They stayed open in March 2020 when our schools closed and have had the highest number of outbreaks and have continued to have exposure to children, unvaccinated children. And so we're meeting with them as well. And I, again, respect as they're navigating accepting and adapting to new recommendations, because it's different conditions than we have in our school age children. But again, outdoors, we haven't seen significant outdoor transmission throughout this entire time, which again, I think further supports the relaxation of the outdoor masking.
Lisa, does everything you've discussed so far include the preschool setting?
Yes.
Okay. What additional measures can a highly vulnerable, e.g. low immunity person take in a maskless environment? And do you think it would be reasonable for such a person to ask others in a classroom to please wear a mask?
I think it's important to have conversations around mask wearing. And I think I shared this example previously. One of our staff went to a meeting where on their name tag, they had red, yellow, and green. So the green folks were ready to hug others. The yellow folks were ready to elbow bump. And the red folks wanted some social distance. And I think that's something we're going to have to learn as a community, is how to have those critical conversations around our risk tolerance. And I usually judge based on a room. And I think I'm so thankful for educators, because I know they're going to have a better answer than me. I always still have my mask ready, because you can usually tell by the sense of a room where people are with their mask wearing. But at the school age level, there might need to be more explicit conversations around the mask, and if someone feels comfortable sharing that personal information, I think that could be a great facilitated conversation to have. Wouldn't continue to be required to wear a mask, but for me personally, if I know someone's worried and I would want to wear a mask. It's a very simple tool I can provide, and if it's something I would consider for at least for a while, it's just to be part of a team and to be part of community and supporting people. There's one other thing I was thinking of when you asked.
So Lisa, there's several questions here. The topic is middle school, and I'll just go through them and then see if middle schools use universal notifications, how would we recommend masks for families of exposed students? If middle schools use universal notifications, how would we direct testing on day 5? How's an outbreak defined? Do we determine when there is an outbreak or reach out to public health? Can you please re-explain how you are doing contract tracing in middle schools? And that would of course apply to high school. So you get the
So we're no longer doing individual contact tracing. So absolutely, number one, if there's an exposure event called public health, our school team is still, FEMA may have ended, our school team is stronger than ever before and is ready to support schools and answer questions on where exposure notices need to go and what's the extent of exposure notices. We know it's more challenging in that middle school and high school environment. We want to be able, what we did in the past is it's no harm to offer testing. If someone's tested positive one place in the community, we know they have a lot of other social networks that are out there. So we want to be able to offer testing on day 5. And I think that's what we're going to be learning together, is what's the pace of new positives in the school environment. We've seen a significant decrease up until this point, and then we'll see what happens on March 14th with the return of school if there's an increase. My hope is that we'll just keep seeing decreases, but that's actually not expected. I'm expecting to see some school-based transmission, and the recommendation around masking at the middle school and high school is going to be harder, right? Because you have so many classrooms, and they just, it's not a contained elementary school classroom. And I think that's where we're going to just see that, if someone's notified and they've been told to wear a mask, our expectation and hope is that they do wear a mask. We're not expecting severe reinforcement of that requirement, again, because cases are going down. And then the other thing I remember thinking about was, if I were immunocompromised, what would I do? If I'm going to teach in a classroom, I'm going to maintain some distance from students. I'm going to wear a more protective mask, KN95 or the N95 mask, wash my hands all day long, practice good respiratory etiquette. I've always added, when I get home, I take a shower, just a good way to end the day after a day of exposure. And that's what a lot of docs do. And so that's what I do. And again, I think we have significant protection, and also knowing we have really high vaccination rates and high booster rates in our student population. So in many ways, Marin County schools are more protected than anywhere else in the nation because of that.
Mm-hmm. Have any county studies been started or done about long COVID cases in Marin?
Yes. So the state has launched a study. We are launching a study. We have a lot of information of everyone that's positive. If we have your cell phone number, you're going to be receiving a survey around long COVID symptoms, and that will be used to inform the local understanding of long COVID in our community. So I'm hoping within the next month or so, surveys start going out into the community. One of the challenges we have is actually long COVID in the children population, especially because children aren't so descriptive of their symptoms and aches and pains, and I attributed everything to growing pains for a while as my kids were growing. So I think that's going to be a challenge for us, understanding long COVID in the pediatric population. But the state is starting studies. We locally are starting studies, and we'll continue to follow national studies. And I think that's one of there are estimates between 14% to 30% of people experience long COVID symptoms, and that's pretty high levels. So again, another reason why we're strongly advocating for vaccinations.
Mm-hmm. Lisa, questions related to, let's just say, returning from spring break. What about all the families that travel to areas that are high risk? Do we have anything for them to make sure that they test before returning? Are you recommending testing after spring break, etc.?
We're not making a universal recommendation for testing after spring break. If you do travel to a high risk area and are engaging in high risk behaviors and socializing and gathering, monitor for your symptoms, and yes, test 5 days after engaging in high risk activities. That's the most protective. That's one of those first. If you're going to cross the barrier, engage in a higher risk activity, the next protective layer is testing, monitoring for symptoms, and then testing after engaging in a higher risk activity. The schools, I anticipate some schools will be distributing tests with the similar recommendations that we had for the return from the holiday. It's not the same conditions. Remember, we were returning to schools. I was scared schools weren't going to open, honestly. We were seeing Chicago and other places in January were not opening schools because people were scared of Omicron. We were really fortunate. Mike Grant's 40,000 requests for tests went through. We got the request in early. And so we were testing when schools returned. If you can remember that chart, it was almost at the peak of Omicron activity. And so that was a time where it was the first time we ever recommended asymptomatic surveillance testing. Moving into spring break, it's very different conditions. We don't have the same case rates. So public health is not recommending testing asymptomatic students after return from spring break. But if individual families have engaged in high risk activities, then yes, you should test yourself and your students 5 days after. And also consider having them wear a mask for 5 days after engaging in a high risk activity when they return to school until you get a negative test on day 5.
Great. Lisa, have there been any reports about any injuries that we've seen from vaccines in Marin?
So there's the vaccine adverse event report. We don't receive county level reports from the vaccine adverse event report. And the first important thing to note is that the vaccine adverse event report is not a confirmed vaccine related event. So it's just reporting a possibility. All adverse events are then investigated. Medical records are examined to determine if they identify causality. I am aware of, because people communicate with me, of evaluations from myocarditis and 103 students who were vaccinated. We had a couple of syncopal episodes when people pass out while they're getting their vaccine. And the most common vaccine side effect or adverse event is just swelling and achiness in the day or two following. So very mild symptoms, which are considered common adverse events in the VAERS reporting system. So, but we don't have a local database where physicians and hospitals are reporting to us vaccine-related adverse events.
Okay. All right, Lisa, I think we've hit our mark. It's 4:01. We appreciate you more than you'll ever know. Congratulations on 2 years of amazing work. We hope you get a good night's rest on March 13th because you deserve it for sure. And so to all of you that have been on this call, thank you very much. Don't forget, everything will be available before you know it, but definitely within 24 hours. Thanks, everybody, very much.
Thank you.
Bye-bye.